All right, so it's September, Prostate Awareness Month. There are some people who think about the prostate all year, like my guest today, Dr. Robert Princenthal, a board-certified radiologist, specializing in prostate, more than 40 years of experience. So he is president and founding partner of Rolling Oaks Radiology, which is part of the RadNet network. And you also serve as a medical co-director for RadNet's Prostate MRI program.
Yes.
Correct. Okay, so let's first talk about that, the Prostate MRI program. What led to the founding of that?
RadNet had a big emphasis in women's health with their wrestling program, and there really wasn't a big emphasis on men's health. And as we know, prostate cancer and breast cancer are two sides of the same coin. Roughly 230,000 men and women each year are diagnosed of their respective diseases, and roughly 30,000 men and women unfortunately die of their diseases.
Yeah.
So back in 2011, there was some interesting research out of the NIH talking about being able to identify tumor nodules within the prostate gland using MR. I went to RadNet and I said, I think this makes sense. I think we can really help men by promoting a prostate MR program. They were a little skeptical, but they said, go ahead and prove your concept. And I think we've been doing that.
Yeah, and it's one of the few focused MR programs, prostate MR programs in an outpatient radiology practice. Is that right?
Well, we were one of the first 5 sites in the country back in 2011 to really make a big focus and emphasis on men's health. And now, of course, it's been widely adapted, and the new guidelines for urology is to get a prostate MR prior to being considered for biopsy.
Yeah.
So the volume of prostate MRs are exploding, and the challenge is getting access to a quality MR, but more importantly, getting access to a trained, experienced radiologist who can provide an accurate interpretation.
Right. Okay, we're going to get to that topic in a minute. But so the let's just go back to the RadNet program for 1 second, because I just want to emphasize the radiologists that are reading the prostate MRIs, they are all specialized prostate radiologists, is that right?
Yes, we have a small team of people who are dedicated to men's health and prostate MR that I've trained and vetted and monitored so that we have great internal quality consistency. And I think the urologists recognize our value to being able to answer their clinical question, to provide accurate reads, and to really help men figure out who's a candidate for biopsy.
Yeah, that's great. Okay, so we're going to talk today about prostate cancer detection. So the first thing I wanted to talk about were some statistics. So according to the American Cancer Society, as you sort of covered, is that 1 in 8 men will be diagnosed with prostate cancer during his lifetime. So, and we know that if prostate cancer is found early, it's extremely treatable. There are 3.3 million men in the U.S. today who have been diagnosed with prostate cancer who are alive. But, okay, so here's where the numbers get sort of wonky for me. So it's very treatable, 3.3 million men alive today, and yet it is still the second leading cause of cancer death in men. And since 2014, the incidence rate has increased by 3% per year and 5% per year for advanced stage prostate cancer. So the numbers, they sort of, they don't totally jive.
Yes. My mission is to make sure that no man should die of prostate cancer. And as you pointed out, if prostate cancer is caught early, no one should die. It's the analogy of women with cervical cancer when they go for their pap smears.
Yeah.
So the problem that we have is that the treatment for prostate cancer 20 years ago was to rip out the gland with prostatectomy or surgical removal.
Right.
Unfortunately, that created for men many undesirable side effects that I call I squared, impotence and incontinence.
Yeah.
And because of that, men felt, well, I'd rather almost have the disease than be living with those side effects. The other problem happened in 2012. The United States Preventative Services Task Force came out with a recommendation against PSA screening. And what they were doing is evaluating from a cost-effective basis, does PSA screening really help save lives and save the healthcare system money? The problem with their guidelines were they failed to incorporate the positive benefits of adding prostate MR prior to biopsy. So as a result, in 2012, primary care doctors didn't order PSAs. And from 2012 to 2018, we've seen a huge rise of men presenting with advanced late-stage cancer simply due to lack of early screening and early detection.
I see. Okay, yeah, I was going to talk about that, about the PSA screening. So the American Cancer Society recommends that men at average risk get screened at age 50, men at high risk, which includes African American men, and those with a first-degree relative diagnosed with prostate cancer before the age of 65, get screened at age 45, and men at even higher risk get screened at age 40. So the screening, as you mentioned, begins with a PSA test. So can you explain what this is?
Sure. The PSA is a simple blood test. It stands for prostate-specific antigen. So the normal prostate produces this antigen, and we can measure that value in the blood. And there are normal ranges based on age. And years ago, people with a PSA of 4 and above were thought to be abnormal and to get a biopsy. That range is now dropped to 2.5.
Oh, interesting.
So we're finding out that PSA alone is sensitive but not specific. Many men with a big prostate can have a high PSA level. What we feel is most important is in our MR reports, we incorporate a biomarker called the PSA density. So we take the PSA level and divide it by the volume of the gland. So in other words, if you have a gland volume of 50 cc's and a PSA of 5, your PSA density is 0.1 or normal.
Oh, I see.
So it's important to normalize the PSA to the gland volume. The problem before this is that urologists would simply look at a PSA of 5 and they would stick needles in that patient's gland every year hoping to find cancer that didn't exist. And that created harms and problems and complication.
Right.
And then that man wouldn't want to go back and get screened.
Right. Okay. I got you. That's what I was going to ask, what the issue was with the PSA. I get it. So the PSA number is relative. It's not, there's no definite.
We also look at the PSA velocity or slope. Mm-hmm. So if your PSA is 4, and next year it's 4, and the year after that it's 4, and it's stable, that's great.
Yeah.
But if your PSA goes from 2.5 one year to 4 the next year to 6 the year after that, that's a doubling, and that's of concern.
Right.
The other thing we look at is a sub-value of PSA that we call the percent-free PSA, which is also very indicative of an increased cancer risk. So there are a lot of internal biomarkers, and we can get pretty sophisticated in addition to just the simple total PSA value.
Right. And is it normal as a man ages for his PSA to go up? I mean, is that just a normal thing, or is that something you sort of hone in on?
It's more the fact that as men age, their prostates tend to get bigger.
Right.
And so many men confuse what we call BPH, or benign prostatic hypertrophy or enlargement, with signs of cancer. We all know men who have to get up 3, 4, 5 times a night to empty their bladder because when the prostate gets big, it makes it difficult to completely empty the bladder. And those are bothersome symptoms, but BPH alone does not have a direct increased risk for prostate cancer.
Okay, interesting. But that is a condition that can also be treated.
Yes,
right. Okay.
Many good treatments for that.
Mm-hmm. Okay, all right, I got you. Okay, so as we were talking about historically, when a patient has a high PSA, he's referred for a biopsy. So there have been a couple interesting studies that I've read, and you and I have talked about this before, about developing an MRI first protocol, which you've mentioned. So where an MRI is performed after a PSA, but before the biopsy.
Yes.
So the results of this one study said that men with a high PSA who have an MRI scan before biopsy, this protocol could reduce prostate cancer death rates by as much as 18% versus no pre-biopsy screening. So can we talk about this?
Sure. It gets a little wonky and gets into the weeds, but the prostate gland before was one of the only organs in the body that was being biopsied without direct imaging guidance.
Yeah.
So it would be like a surgeon trying to find breast cancer by randomly sticking needles in the breast and missing the target. So now that we have adequate ways of really finding the cancer suspicious areas, we recommend that we do MR fusion biopsies with ultrasound by the urologist. So by overlaying prostate MR with PSA screening, many men with an elevated PSA have a normal MR appearance. So those men, we say, you don't need a biopsy. So we can eliminate 20 to 25% of men that normally would have been biopsied to say, you skipped it, you don't need it this year.
Wow.
But more importantly, we can help the urologist find the most aggressive portions of the tumor and miss the low-grade portions of the tumor, so we can more accurately stage the disease and individualize treatment pathways based on good biopsy data.
Wow, and save a lot of men a lot of pain.
Yes.
Pain and suffering. Do you foresee a time that this protocol will become the standard?
It slowly is getting to be the standard. The NCCN guidelines and the American Urologic Association guidelines now are advocating for MR first prior to any biopsy. And a lot of this data came from the Europeans with both the PROMISE and the PRECISE trial, where they looked at men being screened with PSA alone versus PSA and MR and targeted biopsies. So they found more cancers, but what separates prostate cancer from breast cancer is the concept of indolent cancer. So prostate cancer is graded with the Gleason score.
Right.
6, 7, 8, 9, and 10. And the higher the Gleason score, the more aggressive the tumor. But there is a body of evidence that shows for certain men at low risk, if you have a Gleason score of 6 or the lowest grade cancer, those cancers tend to progress very slowly.
Right.
So those men are assigned to a category called active surveillance or watchful waiting.
Right.
Which is different than breast cancer. If you have carcinoma in situ in the breast, the women are getting surgery. But for this, we can delay men needing definitive treatment by many years and improving their quality of life by reducing side effects.
Right. Right. What is the Gleason score? What is that based on?
The Gleason score is based on the pathologist looking at the histopathology of the tumor.
Okay.
And there are two components based on mitotic figures, nucleoli, and all this complex histopathology, but it's now been replaced with grade group disease. It's a Gleason score by just a different name.
Right. Okay. I got you. So sort of staging, but by a different name.
Yes.
Okay. I got you. Okay. So let's talk about a little bit about some other advancements in detection. I know that AI is a big thing and some people get triggered by it, but I know we're using it now. We've implemented it into our breast program, and that may be coming down the pike for prostate. Like what's the deal with AI with prostate cancer detection?
Well, RadNet, I think, is one of the more revolutionary imaging companies, and they recognize that AI plays a vital role for cancer detection across multiple different tumor sites. And RadNet has a subdivision called Deep Health, which is their AI division. And within that division, they have a great product for breast AI, for breast cancer, for lung cancer, nodule detection, for prostate cancer, for colorectal cancer, and also for looking at heart disease. Right. So these are the 5 most common causes of mortality in adult patients. So with prostate AI, there aren't enough good quality radiologists who have a firm understanding of how to read the prostate MR and how to be accurate. So the prostate AI is designed to help someone with less experience than perhaps me to allow their positive calls to approach what we do, but also more importantly, it helps us with the workflow efficiency.
Okay. So, and how exactly does that work?
So the prostate AI generates heat maps, and it calculates the gland volume for us, so we can calculate the PSA density, and it triages basically and helps us look more effectively at the gland so that we can be as accurate as possible in a relatively shorter period of time.
That's very cool. So, okay, let's go back then to MRI screening. So is there ever going to be a protocol, let's say, where men can just have an MRI screening rather than a PSA test?
So that's being evaluated. They're looking at that data now. And I'm involved with RadNet. We're trying to get into population-based health. And we're trying to create something called EPS, an enhanced prostate screening.
Okay.
So our pilot program is designed to look at men from 45 on upwards with a PSA of 0 to 10.
Okay.
We feel that men with a PSA of greater than 10 have a higher likelihood of having cancer, and they should get a diagnostic study.
Right.
But we want to offer a low-cost screening program that we call the mammogram, so it's comparable in price to what women are used to now with their mammograms. So we feel that PSA is still useful, but if you don't have a PSA, you won't be excluded from enrolling in this program.
Right.
And we're doing this without IV contrast. The main difference between a screening prostate MR and a diagnostic prostate MR is the use of IV contrast, which allows us to be a little bit more sensitive and specific. But the articles that have looked at this show that it's less than 5%. But if we can get the cost down to $300 or $400 instead of $800 or $1,000, we can get more men to be screened.
Right. Okay. And so what would be the benefit of that over a PSA?
Well, PSA is not specific. So that if you just do PSA alone, how do you figure out who's going to need a biopsy?
Right.
Biopsies are not cheap and they have risks. But let me just present this in a different way.
Okay.
We've done a lot of research on the cost-effective benefit for screening mammography. And now we have 3D mammography, we have computer-aided detection and AI, and the price of a mammogram now is around $250 to $300. Do you know how many women we have to screen with screening mammography to find cancer?
Right.
The answer is good mammographers find 7 cancers for every 1,000 women they screen who are asymptomatic. When I was doing mammography, when we would recommend a woman for a biopsy, we would find cancer 30% of the time. We would have to screen 1,000 women to find 7 cancers. And yet that was deemed to be cost effective and reduce mortality. Prostate cancer is a magnitude order of improvement because we're pre-screening men with PSA. So our pre-test probability is higher. When I read 100 screening prostate MRs, I find 20 cancers.
Wow.
20 cancers, so 1 in 5 versus 0.7% on the breast cancer side. So what we need to do, if we're really going to reduce mortality, we have to overcome the hurdle of men being afraid to come in and get screened. Just the way women were years ago, they were reluctant to get screened because they thought they would get mastectomy. But now we have breast conservation, we have better treatments, we can reduce the mortality. I can't do anything to help a man who won't help himself by asking his doctor for a PSA, and if it's elevated, get a low-cost screening MR, and then we can triage men, we can find the cancers before it's spread, and we can really reduce mortality.
Well, that was my last question for you, is about just men getting screened. I mean, men are sort of notorious for avoiding the doctor. And
men are babies. I hate to say it. They're just reluctant. So what we really want to do is get the message out to their partners. Because women and partners care about their men. And they need to kind of gently nudge them. Hey, I went in for my mammogram. When are you going to go and get your prostate checked?
Right.
Because same incidence, 2 sides of the same coin, but we need to change the paradigm and have men not be so worried about the side effects, but we want them to save their lives.
Right. I mean, it does seem logical, right? A woman gets a yearly mammogram, right? I don't know why a man wouldn't, just suck it up.
We don't need to do this every year for a man. I mean, if the baseline study looks good and their PSA is less than 3, we can increase their screening frequency from every year to every other or once every 5 years.
Right.
So it's not like we have to do this every year like we do with breast cancer.
Right.
Breast cancer tends to grow faster.
Right.
Most prostate cancers tend to grow slowly. There are, of course, some subtypes of prostate cancer that are more aggressive, and we know that more and more men are getting supplemental testosterone replacement therapy. And the analogy is like estrogen stimulated breast cancer when they were postmenopausal.
Right.
So men who are being monitored on testosterone really need to be careful and make sure they get frequent PSA and prostate MRIs.
Right. And would this be, I'm just going to go back really quick to this, the screening MRI, something that would be especially recommended for men at high risk,
Well, that just changes the age of screening. So as we talked about,
Yeah.
minority men, especially African American, have increased incidence similar to the way black women have an increased incidence and risk of breast cancer.
Yeah.
Part of it is that they've sometimes not been availing themselves of screening. It may not be in their communities, they may not be knowledgeable, they may not have health insurance. So
Right.
there are economic factors as well as genetic factors that play into those increased risk factors.
Right.
The other comment I need to make
Yeah.
is the U.S. guidelines recommend for both men and women stopping screening at the age of 75. I hate to say I'm now on Social Security and Medicare. I feel I hopefully have a long life ahead of me.
Right.
Age is a relative number. You have to look at that to say, do they have other comorbid medical conditions? What's the likelihood that they're going to make it to 85 or 90? Americans are living longer and
Yeah.
we're living better. Don't stop screening arbitrarily at a certain threshold. Look at their robustness, and we can still prevent men and women from progressing with undetected cancer by using screening in a more rational approach.
Right. Yes, absolutely. That's a really good point. I agree completely. And they should change that actually in their language. Yeah. Anything else you want to add? Any other interesting advancements coming along or anything else we want to?
Sure. Well, first of all, September we're filming is Prostate Cancer Awareness
Yes.
Month. And it's always struck me in a curious way that the NFL in October focuses on breast cancer.
Yeah.
And the football players wear pink. They
Right.
have pink shoes, they have pink towels, and you see a lot of players who are at increased risk for prostate cancer. But where's the blue for prostate cancer
You're
awareness?
right.
So we need to really get and raise awareness and let people know that this is the month to really think about being screened.
Yeah.
We've also had really positive advancements in staging prostate cancer. If one of the reasons that men who underwent prostatectomy, the data shows there's a 20% recurrence rate. In other words, even
Yeah.
if you have your prostate out, some men get a recurrent disease, and then the treatment is tough. It's radiation plus hormone blockade. So we have a new nuclear medicine tracer called PSMA, and if we screen with PSMA, we're more accurate at identifying men who may already have metastatic disease, in other words, disease outside of the capsule at presentation. There is a limited role for surgery in a man who already has proven disease beyond the capsule. So we can optimize treatment strategies and save them from a surgery when they need adjuvant therapy anyway.
Right. Yeah. That's great. That would save a lot of people, a lot of lives, actually.
Yes.
Yeah. I mean, I can tell you that from experience another time. But okay, this was a great conversation. And I'd like to talk to you another time about new treatments for prostate cancer.
Be happy
We'll get to
to.
that another time. But this was a great conversation. Thank you so much.
Thank you, Stephanie.
Thank
it's
you.
important to raise awareness.
It really
and
is.
help men and their partners realize they can have an active, good life and not be afraid of the disease.
That's right. Get screened, men. Get out there. Thank you so much.